The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to this afternoon's webinar on the Medicare 2014 payment rule and implications for home care medicine practices. I'm Gary Swartz, and this will be the first of 10 or so webinars this year to help you with your practice. Please remember to let us know the best times for us to get together for these webinars through the SurveyMonkey survey that's available. Also, the topics discussed today will, due to their importance, will be discussed in Frontiers, the e-news, in other forums, and especially at the annual meeting. And you want to be there in May for the important information that's shared both from a policy and a payment perspective, from a clinical and practice organization perspective, and also for the enjoyable networking and opportunity to meet and be with your colleagues and peers around the country. So we look forward to seeing you there. Topics to be covered today. We're going to be discussing in discrete terms the Medicare Part B fee schedule payments through March of this year, services under development for 2015, payments for related services, those related to your house call services, touch on new codes and reporting programs, and discuss the national context, what practices need to decide, plan, and do. And we have Academy advocacy and resources in place for you. This year is a year of policy and payment evolution that will impact your practice, not only this year, but in the years ahead, and we'll discuss this evolution and the important considerations for your practice in the slides ahead. And so it's important with this in mind to talk about the issues beyond the Medicare fee schedule for house calls in and out of itself, though of course that is important for what we do on a day in and day out basis. So again, we'll talk about the 2014 payments through March of 2014. We will look at highlights of the legislative proposals to fix the sustainable growth rate, or SGR fix, and that would provide for Medicare payment reform, as these will impact your payment from April 2014 of this year forward, and also have important implications for practice and payment in the years ahead. And again, look at a couple of codes and services under development for 2015 and after. Medicare Part B fee schedule payments themselves. At the end of last year, medicine was looking at a 20.1% reduction to the Medicare fee schedule absent congressional action. As we know, Congress intervened for 3 months at least, and so we may be back to discuss developments after March of this year. So that intervention kept the 20.1% reduction from taking place, and that would have been a conversion factor of roughly $27, and instead that's replaced with a conversion factor of approximately $35. Congress is currently considering proposals for this year for April forward, with the idea that would also address the sustainable growth rate permanently and establish more global Medicare payment reform. And so again, this year is critical and is viewed by organized medicine as the best opportunity to come along to date to fix the SGR. And however, as we will see, the SGR and reform proposals contain a lot of issues for your consideration as they affect your practice. And these proposals are being considered in the current Washington financial and political environment within budget discussions of requiring pay-fors. As you know, some of your IH colleagues are participating in, Academy colleagues are participating in Independence at Home, IAH, and IAH may be looked at as an opportunity to grow and expand and play a role in these legislative proposals with any savings that may occur as a result of the success of IEH. And the Academy is working to assure that your Medicare beneficiary patients and your practice are supported in these discussions. On a very discrete level, we'll take a look at the fee schedule for the evaluation and management services for house calls. And I realize now that in future presentations on the fee schedule, we need to include the preventive and screening services. And at the same time, here I want to, as we move into the fee schedule review, I want to insert a short commercial. And to help you, we need to become a more data-rich academy. We are asked about how practices pay physicians, nurse practitioners, physician assistants, and their administrative staff. We are asked about utilization, and this is to share with you and as you develop your practices and grow. And we are asked about scope of service coverage and also how practices compare in practice in terms of audits and compliance. So one area we need to have more data to share with you and interested parties is scope of practice and how much in terms of diagnostics, minor procedures, and the preventive and screening services mentioned that are being provided. So it's important that when the Academy provides a survey opportunity, it is to help you and meeting your needs and to respond to interested parties about the Academy and who may be interested in supporting the Academy and helping develop resources for you and the annual meeting that we make those requests. Also, in terms of the preventive and screening services, I do want to make the practice observation that there is no copay involved as it is with the other evaluation and management services. So with that, turning first to the DOM codes, and again, keeping in mind that the congressional
Welcome to GoToWebinar, webinars made easy.
Of last year, producing the $35 and change conversion factor against the RVUs for each service. On the right-hand side of this table, you see the slight 2 to 3% increase generally in payment that you're going to be receiving through March as compared to last year. Let me pause for a moment and mention that what you're seeing here are my calculations of national payment levels using the relative values for each of these services. At the time of developing this, there were not the national payment levels in the CMS database. So this was reflects a calculation of the conversion factor against the relative values. What you also notice at looking at the total non-facility RVUs in the 2013 and the 2014 columns is that the 2014 column, the total RVUs are often less. And this is due to some phased-in reduction of practice expense RVUs and malpractice RVUs, and those are some of the fundamental building blocks of the Medicare fee schedule. So absent the congressional intervention, there actually would have been, even if just leaving the conversion factor the same as last year, instead of being a 2 to 3% increase in payment this year, there would have been a 2 to 3% decrease in payment per each of these CPT codes you see. And just roughly speaking,
Welcome to GoToWebinar, webinars made easy.
A week just to keep equal to last year. So as it is now, you see on the right-hand side that the payment levels for the DOM codes are generally up per level somewhere around 3%. Turning to the home visit codes, we see the same development, and again, this is through March of this year compared with last year, and we see the RVUs slightly less for 2014 as compared to 2013, and again, the phase-in of some RVU adjustments over the years, and again, the percent variance in the right-hand column around 2.5% to 3%. and the payment levels in the 2014 allowed amount column. Again, the allowed amount column reflects that the total amount that Medicare, in essence, approves for the service, and as you know that you receive from Medicare after the annual deductible in the beginning of the year, 80% of that amount, with the 20% remaining to be collected. Then next we move on to the CERT and CPO and TCM codes, again through March, comparing the first 3 months of this year with 2013. Since the RVUs were lower, the reduction in, to begin with, the reductions in practice expense and malpractice for the CERT codes has a bigger impact, and they are relatively flat as compared to last year. CPO has, again, that 2% increase. The transition care management codes, again, relatively flat as compared to last year. We do understand through others and through speaking with you that the TCM codes have not been adopted highly in terms of volumes, and that is, as we know, due to restrictions on their use, the claim requirements and documentation requirements, the bundling of a visit, and the exclusion of other services when rendering and submitting a claim for the TCM. And so you and others in other medical societies with which are the academies interacting, are choosing to render the CPO and the visits themselves as being more cost effective. A service that was in the fee schedule last year, discussed for effect next year, is chronic care management. The chronic care management code is to pay you for non-face-to-face time and that of your staff. CMS was provided, just to tell you a little bit about the background of the chronic care management code, again that would come into effect 2015. CMS was provided with AMA CPT codes and values. You contributed to those values and codes through responding to the survey that the Academy participated in last year's, and we appreciate that. CMS in the rulemaking process last year decided to change those CPT codes to a G code instead, and to frame its availability in some ways like the TCM codes. And they also described this as a move, transitional move, to a patient-centered medical home type of model of payment in the future. So the TCM codes and the chronic care management codes to be, in essence, transitional codes along a healthcare delivery payment and policy development. Also in development is an advanced care planning code. This has come along recently. It wasn't in the rule last year, but we may see it in the rulemaking process this year for effect 2015 or after. Again, you participated in the survey for the work and the value of this code, and this is another effort to get you paid for services you are currently rendered and yet may not be adequately reflected in the current evaluation and management services codes and descriptions and payment. Touching base on the chronic care management code again for a second, it's exactly this your population and services that would make the chronic care management services worthwhile to CMS. And in fact, you're rendering much of that chronic care management now on a non-compensated basis. Turning to the reporting programs that impact payment this year and will impact in the years ahead. A couple of things that we want to note, and I have references here to the materials on the CMS site regarding these programs, is that PQRS and the Electronic Health Record Incentive Programs, there's a clock running on bonus payments. Those bonus payments will be ending this year for PQRS. For meaningful use, so last year to begin, 2016 is the last year for Medicare incentive payments, and that should be 2021 is the last year for Medicaid incentive payments. Want to note about the value-based payment modifier and how this goes into effect. It goes into effect in 2015 for groups of 100 or more, 2016 groups of 20 or more, and 2017 forward for all providers. I want to point out that there's a cost element in the determination of the value-based payment modifier, and that concerns the Academy, and our concern is that unless risk-adjusted properly for your population, that house call providers will appear to be more expensive within a specialty comparison when in fact you, as we know, are cost effective. And there are certain disease conditions, that diagnostics codes that will be considered in the cost measures. They include COPD, heart failure, coronary artery disease, and diabetes. And they are also tied around a index admission, and so it includes an evaluation of A and B cost along with other factors of quality and cost. But the takeaway here is that this is another adjustment to Medicare payments the Academy is paying particular attention to, and we want to make sure that the characteristics of your patient population and practice are taken into consideration. The primary care incentive payment bonus that hopefully many of you are receiving, that's in effect from January of 2011. It is sunsetting January 1 of 2016, and there's a reference to, again, Medicare materials on that program. And so do want to point out that there does not appear to be a movement or vehicle to extend that primary care incentive payment program for your primary care, for essentially the evaluation and management codes that you render beyond the end of 2015. And while it's not the Medicare fee schedule, there was to be the increase in Medicaid payments across the payment to the Medicare portion of the allowed amount for the years 2013 and 2014. We do know that there's been difficulties in some states of getting that arranged and paid to you, and it would be valuable to get your feedback on whether you are seeing, for those of you who are seeing any Medicaid patients that may not be dual eligibles, et cetera, and that you're paid directly from Medicaid, if you are seeing those increases to the 80% amount of Medicare payment. Payment and policies for related services. Relating to DME, while it wasn't in the fees, it was in the fee schedule the prior year, the face-to-face for DME. The enforcement was delayed, but it was not, the requirement was not rescinded, and so you should continue to develop the process of the rendering of the face-to-face for those services. Home health services would mention items beyond the continued constraint on home health payments to home health agencies. There was the reduction of certain diagnostic codes that CMS viewed as being unlikely that patients with certain diagnostic codes would be receiving treatment for in the home, and so that's coming out of the home health agency payment formula. And then not in the payment rule directly last year, but in other CMS regulatory activity, there was a refinement of the definition of homebound under Part A. We've distributed that before, and we'll make that again available to you. Again, that's the definition of homebound under Part A, and not the definition for your services for Part B services. That's something a distinction that we get asked about frequently here, and we'll make sure that that's available to you easily on the site. Telehealth, there was a item in telehealth this year in the fee schedule where the transitional care management service will be paid if rendered through, in part, through telehealth process. However, there's not a direct application to your services and use because the home is not one of the approved originating sites for telehealth. So while a code that you may use is now being covered under telehealth, house calls themselves as an originating site are not covered under the telehealth regulations. And so I just want to clarify that that's not available in terms of the rendering and the submission of the code if rendered from a telehealth perspective. Clinical lab and imaging, similar themes there where services and payments will be evaluated as studies and tests have come online and technology is disseminated and volumes have increased. The base assumptions under which CMS is paying for those services are being recalibrated, so they're beginning to look at those fee schedules and those services and make adjustments to the volume portions of calculations for certain high level of imaging in particular. Incident to services, this is more of a just an observational note and a compliance note. Incident to coverage and payment is not readily accessible or available for the house call population in practice, as that means that your presence is there generally within a facility while the person, the individual working incident to your services is there, and so you're on premises. This is not is more available and relevant in an office setting and facility setting, and is less or seldom relevant in a house call setting from a it just wouldn't be cost effective for two of you to be in the same room at the same time with the same patient. So just wanted to point that out as that comes up from time to time. And what CMS did in last year is to just uniformly adopt that the states, they will follow what the states do in terms of licensing folks for incident to. One area that we are looking at that for you is the chronic care management codes, and we want to make sure that those of you to make use of that service, that the services of your staff are recognized in terms of rendering that non-face-to-face service as much as possible. And so that's one area the Academy is involved for you. So a key issue going forward is what happens March 2014 forward to the fee schedule. One scenario, we'll hit number 2 first, is that their agreement is not reached and cuts are made to the Medicare fee schedule with a permanent resolution to the SGR issue delayed until after the 2014 congressional elections. And that cut could be, whether that's the full SGR cut, we are hearing some ideas that it would be in somewhere in the single digits, low single digits. Nonetheless, that's not a good outcome. Scenario 1 is that agreement is reached and a version of SGR Medicare payment reform proposals are agreed upon and passed. However, these proposals include freezes through up to 2% increases to the fee schedule over the next decade. So each of these scenarios that's playing out now in Congress has significant implications for your practices. This next slide summarizes what these common elements of the SGR fix proposals and implications for your practice. And actually, this is the good news slide. So we've touched on the scenario that agreement's not reached in Congress, and there could be the cuts to the payment levels from April forward. If agreement is reached, many of these proposals include a 0% increase for about a decade in time, up to a 2% increase in the fee schedule on an annual basis over the decade and from the 20s forward. These proposals as elements also include that the penalties for PQRS, EHR, and meaningful use and the value-based modifier would sunset in 2017. They introduce value-based payment programs with bonuses or penalties depending on the proposal, from 4% in the teens to 12% over the next decade. They also introduce alternative payment models, and you can think of these as variations of ACOs and IEH. And if you were participating in those, there would be the bonus potential. But those models, some of them include risk of gain, the opportunity for gain, and also the risk of loss. Some of those do not. And they also include participation in medical homes as an alternative to participating in an alternative payment model. And we will go over this in more detail at the annual meeting. So again, an important reason to attend. Measure development, the proposals generally include some dollars for measure development, appropriate use criteria, quality updates as well. That would be developed by specialty societies. Most proposals include provisions for increased data for physicians to CMS data, so that would help in our practice management, planning, and healthcare delivery, and success under the various models. And then would also provide for greater claims data to be posted for patients and consumers to see. Important thing to look at it here is we're looking at three environments, so this is important. We have a frozen, what all of these proposals include is essentially a frozen fee schedule if you're participating in the traditional fee-for-service model going forward. Alternatively, you have to gear up and participate in an alternative payment model, and some of you already are doing so. Or you have to gear up and participate as a medical home with the standards to be met as they're established. So again, that's why this year is such an important year from a policy and payment perspective, because it's going to impact your practices in the years ahead. We will discuss this more as the year goes on and at the annual meeting, and this is what we all need to be thinking about.